But just to start out, I didn't see at the beginning of his talk, but he must have invited contrary views, different points, different views and different opinions. I'll start out with this by saying I really only want to hear compliments at the end. The mics will only work if you have great things to say about what we've done. No, I'm kidding. It seems like we were here last year to talk about so much that we were about to do, reforms that were about to go on, and it was exciting. And I remember there's someone here, this was kind of infamous in my mind, because someone, after some remarks, said, "You're a socialist bureaucrat." And I still think about that, because I've never been called that before. But we'll see. After the conversation, of course, you'll make your own assessment on how things are going. And I'm definitely interested to hear some feedback. But it's been such an exciting year. Bill got to talk about healthcare reform, which I will avoid as much as I can. It's still a very hot topic. And I've been in conversations with many of you about how our state would not do certain things, would move forward. And I've been enjoying the conversation and relationship about what we would do here in our state. But that's not what today's about. I'm really excited to talk about what our big bets are, what they have been, what we've been able to execute, and where we're going in the future. Certainly take a different point of view on many of the ways to fix our healthcare system. But what we have figured out is that we have far too many problems in our state, in our healthcare system today, that can be fixed with the tools that we have for us to wait. And so that's what we've done. We're going to go over Bayou Health, which is Medicaid's managed care. We're going to talk about really an incredible approach to addressing and to some degree fixing part of our state's mental health system. We'll talk about probably my favorite topic, which is birth outcomes, something that we're making a difference today all across the state. Some things that we don't talk as much about but are equally as important, and that's around how we look at right balancing the care that we provide in the home and in institutions for people with disabilities. And I'll give you a little insight on that. And then government efficiency. We always want to talk about it, and I'll show you some numbers. And things that we're doing in the future are really around how we're investing in systems, complicated computer systems that are giving us the ability to run our business in a far more efficient way than we have done in the last 30 years. So let's talk about Medicaid to start with. We launched on February 1st, and I'm so proud that it went as well as it did, and it's still going very well, Bayou Health. We've had the same Medicaid system since 1967. The number of enrollees has doubled in the last about 10 years, and in that same time, the costs have gone up over 400%. And people are not amazingly more healthy now than they were before, but our healthcare system is costing us a lot more. So our approach to managing the cost for Medicaid was to provide access to more choices for individuals and allow our partner companies to do the work that we've been unable to do over the last 40 years. We picked 5 health plans in 2 different models. 3 are the traditional prepaid. We provide a capitation payment, and then those plans work with the populations that are enrolled and the providers to manage the care more integrated in an integrated fashion, focus on what some of the highest cost procedures were, and that's often complicated births and also people with disabilities. We have 2 plans that work on what we call a shared savings model, and that's sort of a managed fee-for-service. We're testing out these 2 different approaches to managing care with the same eye on quality, integration, coordination, which has caused the waste that we have had in our system. It's caused the high cost for that. We're rolling it out in 3 different regions in 60-day increments. So today, we're a week and a half into the region where we are today. In about 47 more days, 48 more days, we'll be launching in the rest of the state. And then the entire state will be enrolled in Medicaid managed care. We have about 865,000 covered lives in the program. This, I believe, will really change the complexion of how healthcare is viewed in our state. Today, we don't have a big muscle built around how managing care takes place. In Medicare managed care, we do some in the New Orleans area and a little bit here, some in the northeast of our state, but we don't have a large presence. And this is going to be a way for our healthcare system to learn about the process and to engage in the coordination and integration of care. We're very pleased about that. When we look at measuring success, our top priority has always been to improve health outcomes for those enrolled in our plan. And as we move forward in our implementation, what we're seeing is better engagement. This is very early on. Health risk assessments, people with chronic disease, those that have had over the last 8 quarters chronically high costs. Those are the first people that are being engaged. So on the care side, there's a game plan, there's a strategy, and we actually collect 37 different health outcome measures from the plans, which we'll be reporting on a quarterly basis. Will be something to watch, and maybe next year I'll be able to present all kinds of results, which will be exciting. But for now, for the administrative side, for us to manage the rollout of an 865,000 member plan, this is what we look at. Engaging the consumer. Across the country, there's really not a way for people on Medicaid to make proactive choices in a large-scale way. Many states don't do any choices at all. They just say, here's the plan in your region, that's what you have to enroll. We said we want our individuals to go out and make some choices. In the states that do that, national average is 20%. In our first region, we hit 28%. Those are people that are proactively making a decision either through the phone, through mail, or through the internet. In this region, as we get better at doing outreach and coaching, finding Medicaid recipients where they go to make decisions, we're at 34%. We're hoping for the next region that will be over twice the national average at 40%. We'll be very excited about that. Do I have some slides? And this is where our members have gone. Divided up. Some plans have bigger market share than others. We like the fact that there has been good marketing, good promotion, good way to really entice members to join the plan for some value proposition that they have. And it looks slightly different as each of the plans have figured out how to go and refine their outreach and marketing, how to communicate best with Medicaid enrollees to get, obviously, the largest share. The next piece that we think about, again, this is really on the administrative side. It's the provider registry. Sounds like it's just a computer system, which to some extent it really is. But this is the system of record. You see over 33,000 records with 78 fields, very complex system. And you all will probably appreciate this more than any group that I talk to, because when you go to a provider manual and you help employers or individuals choose a plan or provider that works for them, you need good information. Well, Medicaid's never really had good information for 40 years. We've had billing address and provider ID number. We've never been able to help people on Medicaid find a specialist or get to a doctor that's either close to their house or on a bus route. Now we've got the ability to do that. It allows us to manage our program better and the plans to really help the people that are on their plans. Lastly, and anyone would appreciate this if I were giving a talk to, say, the Hospital Association, are the plans paying appropriately? Are they pending too many claims? Are they slow to make payments? And the way we measure our success is that we need to beat the traditional Medicaid program. We need to do it better than we did it before. And basically, we're doing that as of maybe 3 weeks ago. What we found is that the prepaid plans that we work with, they pay faster. 2 of the 3 plans actually pay twice a week. Providers really like having the cash flow be predictable and happen often. And now we're actually, because we have such high-level administrative services within each of the plans, there are fewer pending claims, there are fewer denied claims, and it's an easier process to go ahead and fix claims that are not ready for payment. So on the administrative side, we're very, very pleased with where we're at. We're very pleased about looking forward to the last region, and now we want to focus on improving the quality of healthcare outcomes that we get for the people that we serve. The next piece I want to talk about is mental health. And as I was able to see from the end of Bill's Q&A, it's hard to get people to agree on anything in healthcare, no matter what. And we all enjoy it. As part of the American condition is to disagree on social policy issues, especially something that consumes 17% of our national GDP, at the time, in the place that you need it. And so we went about, this graphic is not just metaphoric, this is literal, because this is one of our state's large mental institutions, East. It's in Jackson. That's what it looks like today. It's actually quite the point of interest for movie makers that come to this area that want to film on our campus. So in the middle of last year, we set out to really address this problem, really take some major steps forward to be able to build a better mental health system. And on March 1st, we went live with what we call the Louisiana Behavioral Health Partnership. We chose Magellan in a competitive bid to be our sort of our administrative services organization. They're the umbrella, sort of the managed care organization for mental health. And we've had many populations that have had access to high-quality mental health services. And then we've had a lot of people, a large portion of the population, whether in Medicaid or uninsured, that just didn't have access except for in the back of a deputy squad car going to an emergency room, or sometimes in clinics when they had space available, when they had slots. And we went about changing that. When we're fully loaded with people in our system, we'll have over 155,000 people. At the core of it, there's 2,400 families. These are kids that today are at risk of an out-of-home placement. They're really the kids with the most complex challenges that are getting care today through 4 different government agencies as well as outside healthcare providers. And can you imagine if you're a parent in a challenging situation with a child with complex needs and you had to deal with the bureaucracy at DHH, at Children and Family, at Department of Education, and at Office of Juvenile Justice? I mean, that in itself is something that needs to be changed. We brought all those 4 agencies together under this umbrella. We have people from 4 agencies that work on the 4th floor of the DHH building, less than a mile away, which on itself is a huge victory for governmental reform. But it's enabled us to integrate the care and services that we have been giving out in duplicative and siloed ways. The rest of the populations are for people that have never had a way to integrate their care. They ping in different places through our mental health system. Could be an outpatient clinic, could be an emergency department, an inpatient stay, and no one's ever able to reconcile the records or track the progress of the care or assure that, say, medications were picked up and renewed at the right time. Under one large electronic health record for behavioral health, we're able to do that. We're tracking and working with the patients so that they don't need to go as often to the emergency room, maybe not at all, and maybe stay in treatment programs where they want to be and have access to drugs when they need them. So the progress that we've made here is really, really remarkable. On the one hand, it's government reform at its best. On the other hand, it's sensible, enlightened, and really working in the real world mental health care. So we're very, very proud about what we've done there. This is what Magellan does as the statewide office of providing this managed care. They coordinate the care for the individuals. They use evidence-based practices. Because they're making payment as a managed care plan, they're able to bring more providers under the umbrella than we had before. And you can imagine if you're providing care for the previously uninsured, it's hard to get providers that want to do work for nothing. And so now we're able to expand the umbrella. They manage quality and outcomes through measures and are able to, for us, bring our costs down. So all good things that we need. Probably the single biggest beneficial factor, as I could explain it to people, is this. One single telephone number for all behavioral health problems. You don't need to figure out who to call and where to go. And if you want to write this number down, if you have people that need mental health attention, this is the right number. If they're a provider in the system, this is also from a provider's point of view, it's pretty nice as well. One phone number to either enroll as a provider or get something fixed in the process, or learn about how to use your electronic medical record, or get access to electronic billing, which all comes free to providers by participating in the program. It's great. Or you go to the website and get all the information there. So great. Two of the biggest reforms in the state's healthcare history for Medicaid and for behavioral health. It's really, really great that we're not just talking about what reforms that we want to do or what our plans are. Now we're talking about what we're doing, and it feels good. The next piece I want to talk about is health information technology. And this offers an interesting juxtaposition on where we're at with regard to health outcomes. If anybody's heard me before, I go on and on. We're 49th in the nation. Our health is terrible as a state. Our stays are longer in the hospital. We use the emergency department. We're more obese. We have more diabetes. And you would say, well, maybe everything's not as good. But what's curious about it is our use of health information technology is among the best in the country. The speed at which our providers are adopting, say, EMRs in the clinical environment or other forms of health information technology is faster than other states in the country. And that just shows that we have an aptitude of improving or becoming more efficient when we have the opportunity. And I think this is really, to me, very promising, showing our potential as a state, having acumen around how we provide care and services. So I want to just talk a little bit more about it. We're one of the first states in the country to stand up what's called a health information exchange. This is a statewide hub where providers can get information about their patients. Say, if you're in a hospital and you want to check to see if your patient has been in, say, another hospital or emergency department recently, or if there are recent labs or images done so you don't have to do duplicative tests, or if you need to get clinical information from the primary care physician, this presents the opportunity to do that with privacy and security. And again, we're one of the first in the nation to do that. We've been able to reach out and have more providers in the community with small clinics adopt electronic medical records in their clinics than other states, which has been great. We have a prestigious program going on in New Orleans to provide access to individuals in a community health center that then links up the computer system with the hospital where they get admitted, so that the community health center sort of functions as part of a large system. We focus on diabetes and cardiovascular care in terms of the transition of care, which brings the overall cost down. Again, less duplication, better information, better health outcomes, and then when the patient goes back to see for follow-up care their physician in a community health center, then that physician has the notes and information from their hospital stay. This is the kind of reforms that we'd like to see start to crop up all around the state, and I think we are. I want to also talk about the number of physicians and hospitals that have taken advantage of getting financial assistance to adopt EHRs. There's really been two great barriers in seeing electronic health records get used around the country. The first is money. The second is it's really complicated and we don't have time to do it. So by providing some financial incentives as a way to see providers buy the software and get help in training, we're able to address the two greatest barriers. And we've done that here in the state. If you could hardly see the push pins, those are practices all across the state, both clinics and hospitals that have taken advantage of the program and now are operating with electronic health records. You might have seen an article in the paper today or yesterday. We were the first state in the country to go out with what we call meaningful use payments. And that indicates that we have both hospitals and clinics that now are demonstrating that they not just have an EMR in their facility, but they're using them in a way that earns the level that's called meaningful use. And that's objectively measured. It's I will say, it's not easy to achieve. It's not difficult. You've got to work at it. But that means that patients get enormous value out of it in terms of their care, and the payers get a lot of value out of it in terms of eliminating the duplication, assuring that providers are using the information to either support their decisions or inform the care choices in front of them. And so I feel very, very proud of our state and our providers around the state for earning the distinction of being the first to be able to get to meaningful use. Not Massachusetts, not Minnesota. It seems like every article I read is about one of those states, or Oregon, but right here in Louisiana. Not just about football. It's about electronic health records, too. So this next thing I want to talk about is really, it became one of my personal campaigns when I first got here. About 2 weeks after I took the job a couple years ago, we got a call from the March of Dimes. So we'd love to have you appear with us on the steps of the Capitol. We're going to do a press conference, and we want the Secretary of Health to be there. I said, oh, I love March of Dimes. Great. I did those walks as a kid. It's going to be great. 2 weeks later, the information pack comes. It's Louisiana's report card, and we're getting an F. And I've already committed, because I probably would have had second thoughts. So we got an F because we are atrocious at our birth outcomes. And this is not something that is ephemeral or doesn't impact us. This is for real stuff. 49th in the nation. This 49th is the second to worst for infant mortality. 47th for low birth weight babies, and 48th for prematurity. And Medicaid pays for over 70% of the births. So imagine if any of you was the CEO for an insurance company that's turning out those kind of results, your board would have to question if you're fit for the job. And I did the same thing for Medicaid. How can we be doing such a bad job? There's a lot of complicated factors that go into this. It's not just can you change a policy and all of a sudden every baby is healthy. But we definitely went to work in trying to address this. One thing that's great about dealing with births is they more or less take around 9 months. You don't have to wait 15 years to see what's going to happen. You're always having babies. We have about 65,429 babies a year here. Our rate is pretty flat. But that means that we're paying for somewhere around 40,000 plus births. We went to work right away on things that we could change on that day. And so we started behavioral health screening. Too many women were having babies that were still addicted to certain things, drinking or smoking, cigarettes, or even drugs. And we needed to get in. What we heard was, yeah, you could do the screening, but then they have to go on a waiting list to get care. Come on. That can't be the case. So we put pregnant women top of the list as soon as they get screened. 17P is a drug that for women that have had a preterm birth that will help prevent a second preterm birth. And we weren't covering it. Very simple $25 course, very good investment for us. But the last piece was 39-week initiative. So we know babies, really healthy babies are worth the wait, in the words of the March of Dimes. That we should not be supporting policies in hospitals or with OBs that make having your baby before 39-week an option if you just feel like it. If you want to have some family in town or a shopping trip scheduled for the next week. You should wait. And when we went out and we asked hospitals to sign a pledge with us, they said, well, this doesn't happen here. And the OB said, well, I never do those. But we brought data to them. And both the hospitals and OBs were a little surprised with what was going on when you aggregate the data and show. And once we had their attention, once they knew that this was a problem, they were on board. And so it took us a couple months, but we have every single hospital that does births has signed on to the pledge. Again, to not wait, or rather to not do voluntary inductions and to wait for at least 39 weeks. Now, it really matters because you can see the second bullet, 14 hospitals have gone from an average of 15 to 7% of elected delivery. So we still have ways to go, which is good. We don't take all of the benefit right away. Women's Hospital, a 20% decrease in NICU admissions. So just from the insurance perspective, if you work on a book that has working age people and you know you're covering a fair amount of births, this impacts you as well as Medicaid. This is for everyone, every single hospital. You know what a NICU day costs you. and you know what ride home in the car seat the next day after a birth. You know you're done. You're in the hospital 1 to 2 days, have the baby, everyone's happy, car seat, go home. The alternative is have the baby early. It's still taking time to bake in the oven. It's not in the mama's belly, it's in the NICU. And those days are pretty expensive. And if the baby doesn't need to be there, we'd rather it not. And we'd rather there be space in the NICU for babies that really need it. And that's what we've been able to do. And it's just so satisfying knowing, just at Women's Hospital, it's the busiest birthing hospital in the state. So a 20% decrease is something like 400 babies, and that was in 6 months. So this is continuing to go. 400 additional babies went home in the car seat, not in the NICU. That is really something. And so I'm very, very proud of that. Now we're continuing on because there's still a lot that we can do. We need to get out of 48th, 47th, 49th place. We need to be number 1. Now we're not going to get there tomorrow, but it's something that we need to strive for every day. These are the kind of things that we're doing. We know what works. We're trying our best, and we're working with other provider organizations to improve every day. You can see we've worked very closely with the March of Dimes, with the Hospital Association and OBs, and we're very, very happy. We also accepted another challenge from the March of Dimes to reduce our prematurity rate by 8%. We're the first state in the country to do that, and we did it without any hesitation. And I secretly think that even though we have 2 years to do it, I bet we hit it in 1 year, when the data shows that this is the most ambitious state in the country to improve birth outcomes, and it feels great to be in that place.